Well, it's a little after 7 o'clock, so I thought we'd get going. It's exciting these last few years where we've had the chief residents give a summary of some of their research. And I know as a department, we're all excited to give the residents an opportunity to pursue interests and to try to move the field forward. And Peter, do you have any opening thoughts you'd like to make here?
No, I think you've said it well. This is something we value in the department, and we'd like to promote.
Yeah, good. So obviously we've got our three great chief residents, and we're going to start with Avi Baskin. Avi, the floor is yours.
Thank you, Dr. Stoller. How does that look?
That looks, let's see. Maybe do the...
How about now?
That's better, yeah.
Okay. Thank you so much, Dr. Stoller. I'm Avi Baskin, one of the chief residents at UCSF in urology, and really privileged and pleasure to be talking about some of the research from my year last year in Dr. Quigley's lab. I just want to start out by thanking him for a great year. I learned a ton, both on the in terms of cancer biology, but also in terms of the practicalities and logistics and programming that it takes to do this type of research. So special thanks to him. Today I'll be talking about the genomic and transcriptomic-based mechanisms of recurrence and progression in high-risk prostate cancer treated with neoadjuvant docetaxel and androgen deprivation therapy followed by prostatectomy. So as we know in urology, men with high-risk prostate cancer can be fatal. Men with high-risk prostate cancer are at a high risk of progressing to metastatic disease and dying of prostate cancer, and there is a need for additional lines of therapy for these patients, some who may not be metastatic but have high rates of progression with standard treatment. In the past, there's been multiple trials, specifically a trial looking at chemohormonal therapy prior to prostatectomy in the neoadjuvant setting. This trial specifically looked at docetaxel and neoadjuvant ADT followed by prostatectomy. While the 3-year biochemical recurrence outcome did not differ between the groups, there was in subset analysis improvements in metastasis-free survival, overall survival, and overall survival in those who got neoadjuvant chemotherapy, basically saying that there potentially could be rationale for future study in this area, looking at who may or may not be responders to this therapy based on information. We're looking more specifically if genomic or transcriptomic information at the time of prostatectomy can be used to predict who will respond to chemohormonal therapy. I was very fortunate to come in and work with a data set and a study that had been going on at the University of Wisconsin for multiple years prior to me joining the lab. This study looked at 30 patients with newly diagnosed high risk or oligometastatic disease. And all of these patients, you can see here, got ADT and docetaxel, and then all of the patients had a radical prostatectomy. And these were the primary endpoints, PSA and pathologic response. And then we looked, and then this is just kind of a sense of the data that we had, PET CTs prior at the time of diagnosis, followed by the docetaxel and ADT, and then also PET CT at the time right before prostatectomy. I just want to give a sample, a sense of the tissue that we had. So all the patients were treated again with docetaxel and ADT, and then afterwards the prostate tissue was taken and basically sampled and sorted for different features. We looked at different immune features and then also epithelial features to look at the tumor samples, CD49 to look at different immune features and compare, and then went through RNA-seq. This just gives another sense of the whole genome sequencing and the exome sequencing that had been completed. And here's an example of taking different foci from each prostate. So I think one of the strengths of this particular study is that each prostate, rather than kind of being lumped in and having kind of one genetic score, had multiple different foci across the tumor and also across the gland, which kind of let us make some different comparisons. So the aims of the current study and the things I want to just focus on down on for today was one, clinically, how do patients respond to ADT and docetaxel was an effective treatment? And then second, is there an association between gene expression and clinical progression / recurrence based on PSA? So first, in terms of the PSA and how patients respond clinically, you can see the PSA baseline is high and expected, 23, which is totally reasonable. After getting ADT and docetaxel, the median PSA was 0.2, and post-prostatectomy, the median was 0.1. So definitely a high-risk group, but responded according to what we would expect out of patients having ADT and docetaxel. And then this is just a graph of that, looking at the PSA over time. So quite high responding to treatment and post-prostatectomy. But to give you a sense, this is again, a high-risk group, right? So even with the ADT, docetaxel, and the prostatectomy, over time, about 50% of patients had recurrence based upon, or more than 50% had recurrence based upon the PSA value. So still quite a high group, despite high risk of recurrence despite all of those treatments. So evidence of response to therapy based upon PSA decrease, but evidence of recurrence in the long term. So the cohort it does make sense clinically. The next question I want to focus on is there an association between gene expression and clinical progression / recurrence? We did this based on PSA, just an overall map. So we looked at the gene expression in those who progressed versus those who did not progress. Basically, this is just kind of a heat map. So the way to understand this heat map is on the y-axis up and down are different genes. And then on the x-axis side to side is basically each foci. So again, each patient had multiple foci, but this basically looked, and then I also clumped them by those who progressed and those who did not progress. And you can see generally, if you take a step back, that they're for different genes, and I kind of picked out some with kind of a neuroendocrine type expression pattern, but for different genes, there was a higher expression of these genes in those who progressed who did not progress. But overall, when we look at this, you're trying to pull out themes and overall kind of takeaways from the research, and you're wondering if there was kind of a neuroendocrine pattern that we were seeing early in those who got the treatment, which is something that I think we're used to in kind of later stage prostate cancer. But another way to essentially look at this is to look at these hallmark pathways. So we looked at average gene expression across 38 hallmark pathway. Each of these gene sets is made up of 3,200 genes, and I'll show you the different ones that we looked at. And they're basically calculated by averaging the expression of each gene in the set. And then again, we compare it to early progression versus late progression. So these give you a sense. You may have heard of these different types of pathways here, but if we kind of hone down to it, there was looking at an increased type progression. So blue is early, which is within a year. Red is late, looking at green versus no progression. And the EMT, the epithelial mesenchymal transition pathway, was upregulated in those who progressed, who had early or late progression, and then angiogenesis. So kind of looking at that overall, we know that this epithelial mesenchymal pathway has been implicated kind of in metastatic disease, especially in prostate cancer, and suggesting that these gene pathways are upregulated from an early stage may kind of give us more of an insight into the pathophysiology, pathogenesis of prostate cancer, especially after kind of heavy treatment they've undergone. So overall, patients did have a response to ADT and docetaxel, and many did recur. And then there was, initial suggestion that those who did recur progress had upregulation of these epithelial mesenchymal transition pathways as well as angiogenesis pathways. So just want to take again a moment to thank everyone I've worked with during the research year and beyond, especially Dr. Quigley, who took me into his lab, and all the other lab members who were extremely welcoming and helpful. And really, for someone who's never done this type of work before, we really took a lot of time out of their schedules to help me with, just kind of basically everything from, the basics to the more advanced stuff. And then also thank you to the team in Wisconsin who had me on to work with a lot of the data they'd spent years working on and gathering. And then finally, thank you to all the folks at UCSF, especially, obviously the Department of Urology, letting us, supporting us for a whole year of research is incredible and something that many people don't have the opportunity to do. So really appreciative of that, and thankful for the training program and the next steps. So happy to take any questions.
Avi, I saw that the preoperative PSAs on the patients varied quite a bit. If you just looked at PSA and looked at the endpoint versus looking at those who received the chemo before the surgery, was there a difference? Could you just segregate them just based on preoperative PSA? This is from a non-oncologist.
Yeah, we could. I mean, you can look at it a variety of ways, but we potentially could. I think, many of the patients had a higher PSA, but there was definitely variability. Like one patient I remember had like up almost at like a 300 or 400, but you could potentially look at PSA and try to divide, the analysis in that way. That's something we could approach.
Avi, this is Peter. On that same point, you actually looked at your recurrence-free survival was actually quite good for a high-risk population. So as a point to Marshall there, I think using a Capra score, a multivariable risk model, is better than just a risk category. So I'm sure there were some high-grade, lower volume, lower PSA patients who might do quite well. So I think a clinical, but a multivariable instrument I think is quite good. I got a call right when you were presenting there, but did this predict for response to secondary treatment as well? So a lot of these people, when they failed, got therapy, and we do know that the combination of docetaxel augmented hormonal therapy now in men who fail after surgery, so non-metastatic hormonally sensitive cancers, actually do better. I mean, the randomized trial showed that. So did this predict for response to secondary therapy? Did I miss that?
We didn't look at that specifically. Many patients did, obviously, when they fail, end up having that, but that's not something that we looked at, but definitely can going forward.
Yeah, because the biology of the tumor is likely reflected in the biology of the metastases. So I might look at secondary outcomes and predictive models. You may have a model that predicts for response to systemic therapy, period, no matter what disease state you started. But very nice work.
Avi, there's a question from Max who wants to know, are you able to do these analyses from samples from 90203?
They had done a similar analysis. Potentially, I mean, you could. I don't see why not. It'd be a matter of kind of the collaboration. I think we had a little more detail in terms of my understanding from that study is that they had, I don't want to speak, but they had, we have a little more detail in terms of multiple foci per patient rather than just one particular patient. But I think you probably do something similar with that study.
There is widespread involvement on this talk. Carissa zoomed in from New York and wanted to know, great work, Avi. Is your gene expression analysis on pre or post neoadjuvant treated tissue? And what is your hypothesis on whether Dosi ADT could be driving a more neuroendocrine aggressive phenotype? Or do you think these are more aggressive tumors to begin with?
Yeah, thanks, Carissa. I think one of the aspects that as we were, performing this work and looking at the data, we didn't have pre-treatment gene expression data, and that you kind of need that to essentially say, were these, were these tumors already like this before or after? So they were all post-treatment, which doesn't really allow us to comment on that, but that would be something that I would hope to look at in the future as well and get our hands on that data.
And I see that Dr. Quigley said the samples obviously studied were post-treatment, but we were about to receive pre-treatment biopsies from Madison. Thank you, David. Avi, can you take some of this work with you when you go to Vanderbilt, or are you going to have to hand this off to David and the team here?
Well, I mean, I as far as taking the project, there's obviously a big team working on it, and I know David's, Dr. Quigley's continued to kind of work on it as I've been involved clinically this year. I think, one of the nice things, either way, I've learned so much, and there are people there who do similar work that I feel like I'll have some skills to kind of offer and hit the ground running, on similar type projects or continue to collaborate. So, I mean, either way, yeah.
Well, Avi, great work, and it's very exciting what you're able to get accomplished in this year with the tutelage of Dr. Quigley et al. And the folks from Madison. So great job.
Thanks, Marshall.
Mira, I think you're next on board here.
Yep. All right. I'll share my screen. Okay, does that show it for folks?
Looks good.
Okay, great. So my talk is titled The Transcriptomic Heterogeneity of Expansile Cribriform and Other Gleason Pattern 4 Prostate Cancer Subtypes. To start off with some background, there are 4 main subtypes of Gleason pattern 4 prostate cancer that you can see on the right of the slide here: cribriform, fused, poorly formed, and glomeruloid. And so, why do we care about these different subtypes of pattern 4? Well, some of studies, especially some stuff that has come out of UCSF, has shown that cribriform has been associated with worse clinical outcomes following radical prostatectomy. And this is true in several cohorts and as well from multivariable modeling in these studies. And also some work that's come out of UCSF and other institutions, we can further substratify cribriform into expansile or large cribriform, which are the same, and then simple or small, which also mean the same thing. And that's basically looking at the number of lumens that are present. And why do we care about this further subclassification? It's because there's some data that's shown that expansile cribriform compared to simple cribriform is actually associated with worse outcomes and also worse genomic scores. So given the difference in clinical outcomes based on these Gleason pattern 4 subtypes, there's been some interest in looking at the genomics of cribriform prostate cancer. And so shifting to information about prior studies that have been done on the cribriform subtype. So some of the important studies, one thing that's important in these studies is that they often group cribriform with intraductal carcinoma. And the reason that these two get grouped together in studies is because they morphologically look similar. And also they are both associated with worse outcomes. So the way to tell the difference between cribriform and intraductal carcinoma is to actually stain for basal cells. And oftentimes that's not done by the pathologist because it wouldn't really change clinical outcomes for patients. So that's why these get grouped together. And I'm also going to be doing that for this talk that I have as well in the study that I did. The second important point is on these prior cribriform studies is that they included patients with all Gleason grade groups. And from these studies, we know that the cribriform group tends to have a higher percentage of patients with Gleason pattern 5 disease. So it's possible that the results from these prior studies have been confounded by the fact that the cribriform group has a higher number of patients with pattern 5 disease. And lastly, there are no prior studies that have, characterized very well the transcriptomics of the other Gleason pattern 4 subtypes that I mentioned, so fused, poorly formed, and glomeruloid. So with this background, that brings us to kind of the objectives of the study that I worked on during my research year. And so the first objective, there are 3 main objectives. I'm going to focus on the first objective first, which is to characterize the transcriptomics of each Gleason pattern 4 subtype through exploratory data analysis. And in order to do this, the technique that was used was heat maps of normalized hallmark gene set scores, and I'll explain that a little bit more. So getting to our analytic cohort, the inclusion criteria for this study was patients who underwent radical prostatectomy at UCSF and then had a Decipher test sent on the radical prostatectomy specimen. And so when you send that Decipher test, you do get you get the Decipher score, but the Decipher, they have a whole grid where they get transcriptomic data of about 46,000 different gene expression variables of different genes. And so here you can see that we excluded patients without Gleason pattern 4, without Gleason pattern 4. So there's one patient that had grade group 1 disease on the prostatectomy specimen. And then importantly, we excluded all patients with any type of pattern 5 present. So this included tertiary pattern 5. And this got us to our analytic cohort of 165 patients from our UCSF database. The pathology was then re-reviewed by one pathologist and was looked at for all the different subtypes of pattern 4. And we actually ordered in each prostatectomy specimen, you could have multiple types of Gleason pattern 4 present. So because there were multiple types of Gleason pattern 4 present, we kind of ordered them from best to worst. So if a patient had, fused poorly formed glomeruloid and expansile curviform, then they would fall in this expansile curviform group. So you can see in our cohort of 165 patients, there were 99 patients that fell into the expansile curviform intraductal carcinoma group and 66 patients that were in the non-expansile curviform group, so these other pattern 4 subtypes. So like I talked about, the next slide is going to go into the heat map, which basically looks at the normalized hallmark gene set scores, and it's grouped by each of the Gleason pattern 4 subtypes. So to explain how to, Avi kind of went through this a little bit, but to explain it again, so each of these columns is a patient, and each row is a hallmark gene set, which contains multiple genes and refers to different biological pathways. And so the colors here correspond to if there's high expression or low expression for a given patient. So red would be high expression and blue would be low expression of that hallmark gene set pathway. And so in these 165 patients, this is the fused poorly formed group, and then this is the glomeruloid group, this is the simple curviform, this is expansile curviform, and this is intraductal carcinoma. And the hallmark gene sets themselves, each row, which is a gene set pathway, there are pathways that are similar. So all of these in this dark green kind of pathway here are the ones that are associated with cell cycle, so like proliferation, cell proliferation as well. So we're going to focus on the expansile curviform and intraductal carcinoma group here. And if you look in the cell cycle group here, you can see that the majority of patients that have red or high cell cycle proliferative activity tend to be in either the expansile curviform or in the intraductal carcinoma groups. But you can see here that there's also heterogeneity, and that when you look in this group here, it's not like all of these are red here. So there's actually heterogeneity present here. There's some patients with expansile curviform subtype that actually tend to have a high expression of migration and invasion gene sets, or a high expression of immune response, or high expression of steroid cells. So you can see here that we're not seeing big blocks of red within each of these subtypes, which shows that there's transcriptomic heterogeneity present within each pattern 4 subtype. And this is kind of a novel finding. And so the fact that there is heterogeneity present, then motivated us to do further subgrouping of the patients based on these transcriptomic, information. And the second thing is, does this heterogeneity that you see maybe correlate with clinical outcomes? So that kind of brings me to my second objective for the study, which was to use these transcriptomic features to group patients without pattern 5 disease. And this was done through consensus clustering using the hallmark gene set scores. And then a second after that was a heat map for visualization of the data. So looking at our cohort, so this was a package that you can use where you take the hallmark gene set scores and you basically create a bunch of different clustering solutions. And the way that you pick the cluster, the number of clusters, is you look at each time you add an additional cluster, it's going to explain more of the variability in the data. But at some point, you basically reach a point of diminishing returns where when you add an additional cluster, it doesn't really help explain a significant amount more of variability. And so for the data that I had, we ended up choosing the 4 cluster solution as the robust solution. And so this is just showing you kind of the hierarchical, clustering that then results in this outcome. And so next we did another heat map. And so this heat map, instead of being ordered, each of the columns, being ordered by the pattern 4 subtype, it's actually ordered by each of the different clusters that each of the patients fell into. So like I said, the solution that we came to was a 4 cluster solution. And so here you can see that this cluster was named, the proliferative cluster, because there's a high activity of these cell cycle gene sets in here. And then this cluster was named the steroid hormone cluster because it has a cluster of patients with high activity in this. And then this cluster was named the epithelial mesenchymal transition cluster because there's high activity here. And then this third cluster was named after the immune response because there's high activity of these immune cells. So you can see here that within each consensus cluster, there are patients of each different type of pattern 4. So you can see that expansile cribriform and intraductal carcinoma, which are the dark in this here, tends to be in each of the different consensus clusters. But the proliferative cluster did have the highest number of patients with expansile cribriform or intraductal carcinoma pattern 4 subtype. So this basically shows that, that there is heterogeneity present, again, kind of like the last heat map. And so my next question is if I, if I look at these consensus clusters, do they potentially add prognostic information in terms of clinical outcomes for patients? So getting to our third objective was to determine if there's an association between transcriptomic heterogeneity and the intermediate term clinical outcomes, which for us was biochemical recurrence. So to do this, we did some survival analyses of biochemical recurrence-free survival. So here we are looking at Kaplan-Meier curves, and these are for each of the consensus clusters. So here you can see that the proliferative cluster tends to have the worst biochemical recurrence-free survival, but this is looking in like a univariable model when you look just at the Kaplan-Meier curves. And then you can see the immune cluster tends to have the best biochemical recurrence-free survival. And so here in the table, I've shown first in the univariable model, you can see that the immune cluster tends to have the best biochemical recurrence-free survival. And in the univariable model, being in the proliferative cluster is actually associated with worse biochemical recurrence-free survival. And also, importantly, the CAPRA score is predictive, of which kind of validates the model and, the outcomes that we have. But you can see here in the multivariable model, when we start to control for all of these different genomic scores and different factors and whether expansile cribriform and intraductal carcinoma is present, you can see that actually the steroid hormone cluster is associated with worse biochemical recurrence-free survival. So I think this is because in cluster 4, it being proliferative, you tend to see higher cell cycle scores and see higher genomic scores. And so the kind of badness that's associated with being in cluster 4 is captured by the current genomic risk scores that we have. And so when you control for that, then you actually see that the proliferative cluster is not associated with worse survival, but that the steroid hormone is actually, that's what adds additional prognostic information as being in that cluster. So, the conclusions from this study are, 1, we demonstrated that there is transcriptomic heterogeneity present within each Gleason pattern 4 histologic subtype. And we found that, the consensus clusters that were created using this transcriptomic heterogeneity were, one cluster was associated with biochemical recurrence-free survival in our multivariable model. This suggests that, this transcriptomic clusters that were created or other different transcriptomic signatures may be able to improve risk stratification beyond conventional measures of risk, such as the CAPRA score and other genomic risk scores. And then I think for future directions, trying to validate these findings in other cohorts or as our follow-up, matures as well to look again at these same different clusters. The other idea would be, just to develop additional transcriptomic signatures or clusters and not necessarily use the ones that were in this study. And then I think a third final direction that we're kind of looking at or trying to look at is, can we figure out whether these different transcriptomic clusters are actually associated with response to adjuvant or salvage treatments and help us decide which treatments patients should be getting after prostatectomy if needed. So I'd like to thank, Dr. Fang and Dr. Quigley and, all the members of the lab who, like Avi said, spent a lot of time teaching us and listening to our questions and listening to our presentations. And it was kind of a great experience to work with all of them. This is when we did a Secret Santa at our holiday party. It was just great to kind of be able to interact with them and, listen to their presentations at lab meeting every week. And I'd like to thank everyone in the department as well for their support. And I'll take any questions.
So how do you develop new transcriptomic signatures? How do you determine how you put these groups together to form these signatures? I'm not familiar with that.
Yeah, so for this one, it's the type of consensus clustering that was used. It basically, it will create a solution where it looks at which two are kind of the closest to each other and then puts them together, and then look at which one is the closest to that one and puts them together, and then it creates that that map that you see there. And then so I actually looked at solutions that were from 1 to 10 clusters. You can tell the program how many clusters to create. And then you actually get an elbow plot where it actually, so every time you add a cluster, it's always going to explain more variability. The question is when you get from like the second cluster to the third cluster, what's the additional variability that you explain by adding this additional cluster? And at some point you get to the point where adding an additional cluster doesn't really help explain a significant more amount of variability. I guess that's kind of a little bit of, there's not like a cutoff, but a little bit more of, I guess, the art of like deciding when you look at the data is, do you think that it should be the 3 cluster solution? Do you think it should be the 4 cluster solution? So this method used a partitioning around medioids, which is basically you take, it's like this nth dimensional space where a medioid is created and looks at it, compared to the other, all the medioids for the different samples. So you can use different algorithms for what you use to explain it. And so different classifiers that you see will use different algorithms to create actually the clustering. I don't know if that is a good explanation.
It's just trying to find that sweet spot where you get that right combination. Yeah.
Yeah, exactly.
Yeah. Dr. Chu, also, Chris from New York says, amazing job, Mira. Do you know if the Decipher grid was sent specifically on the cribriform region of the slide? Or do you think this transcriptome reflects a bad neighborhood in general?
Yeah, so that's a good question. We don't know that it was specific. It was definitely sent on the highest grade, of tissue, because that's how we send the Decipher. But yes, Chris is correct. We don't necessarily know if it was sent from the area that specifically had the cribriform. I think when we talked with the pathologist, they said that, preferentially they probably would send it from that area, but we didn't go back and kind of, look at where it was sent from. And I think maybe the idea would be, like you said, even if it's not specifically sent from the cribriform, it has to do with the tumor, the tumor characteristics that are associated with having the cribriform disease in it, even if it wasn't sent specifically from the cribriform part.
Heiko, want to know, great talk, Mira. Are you surprised that the pathologic appearance doesn't correlate with the transcriptomic profiling? Or do your results suggest that we might eventually reconsider the use of histology to risk stratify patients with pattern 4 disease or prostate cancer in general?
I think what I've learned is from this year also is whenever you look for heterogeneity, I mean, I feel like you always find heterogeneity.
Right.
So I'm not necessarily surprised that I found heterogeneity. Initially when I started the year, yes, maybe I would have been surprised that I found heterogeneity, but kind of from reading papers and, reading, kind of from the methodology of doing, Z-scoring stuff, you're kind of always going to probably find heterogeneity is what I feel like from our understanding right now. So I'm not surprised that I found heterogeneity. I think it suggests that the histology can only tell us so much. And so we actually need some sort of combination of probably, looking at the histology and with a combination of the transcriptomics. And so, maybe trying to be able to incorporate both, which is kind of what we do, clinically every day in clinic, is taking, additional pieces of information and adding them together. So I think, the reason that the histology is important too is because people can kind of do it everywhere where there's not access, I think, to, running transcriptomics on, for every patient isn't really feasible in some places, but maybe it's easier to kind of teach people how to do the histology and look at the pattern 4 subtypes. So I think, there's still a role for both.
Mira, on that point, I just want to make a point that the key is whether we're getting the most out of pathology than we currently are. And what the department's doing now is scanning slides nightly, because we think AI technology may allow us to do pathology much better. And I think the real key will be, if we do that, do we need genomics? We're scanning about 250 slides each night in a large cohort of men, both on surveillance and after surgery. to see whether or not we can predict outcomes as good as genomics. And, you know, Felix has some preliminary data that suggests that we can. So, and that's very exploitable. So I do think that's an opportunity. And for the rest of the department, you know, we own these scanners. So if people have a real interest in histology, we have the technology to scan the slides, and we can partner with a group we're doing currently, but it could be anybody that look at whether or not AI can enhance predictive power of
and then, for that segues nicely into I think for fellowship, my proposed project is to kind of use the AI technology in Artera, use this kind of decipher grid, and then look at like polygenomic risk scores. So kind of try to compare a couple different types of techniques and see what ends up kind of doing the best. But yeah, I think the AI technologies.
Yeah, and on that note, we just sent UW 377 images just this last week, and we're doing more as well.
Yeah. Awesome. Thanks, everyone.
Great job, Mira. Really exciting to see all this work. Alan,
Thanks,
you're on now.
Top of the morning to everyone.
Good morning.
So my talk is it's called Age is Just a Number. And we see here, this is my very first day of intern year 6 years ago. I was a lot better looking then, more hair, a little less weight. I'm not sure where my white coat ended up, but haven't worn that since. But it's been a journey for sure. I know usually we wait till the end to give shout outs, but I wanted to give a shout out to my main mentors here. I found the youngest pictures the internet had to offer to go along with the theme. But I really appreciate all these mentors because they kind of taught me how to be a mentor myself. And the main thing I take away from them is, you know, they made me realize that I don't have to fit into a perfect, a perfect bubble. And, you know, it's okay to be unique in certain ways. So the way that I've been mentoring my junior residents is that this is a cookie, cookie cut. I think we always want to have the cookie cutter perfect resident. It fits into the cookie cutter, but I think you have to meet folks where they are. You can't expect them to be exactly the way you want them to be. Sometimes you have to change your teaching to get the best out of folks. And I learned that from my mentors. So this is Avi, Mira, and myself. And as you see, if we go into the cookie cutter, we're leaving a lot of cookie behind. And so we're losing out on a lot of potential. And so that's the way that I've been teaching my juniors. For example, Walter responds, a little more to harsh criticism. And then others, you have to be a little more gentle with them. So I adjust based on my mentees. So I just want to give a shout out to my mentors. And so through my research year, I love academic medicine primarily for the teaching aspect. I love teaching the junior residents, and that's what's driving me to pursue a career in academic medicine. During my research year, I was named a STAR scholar in the National Institute on Aging. And so they funded my research year and allowed me to take courses in the advanced training in clinical research via UCSF. And so the NIA is who paid for me to take courses, which further allowed me to pursue education and learning, which is what I'm passionate about. So for this talk, obviously it's focused on age, and this is the AUA guidelines for urethral stricture disease. And so a couple of main things are that we know that endoscopic management of urethral strictures essentially has no long-term effect for long strictures, and definitely almost 0% long-term effect for managing if there are multiple endoscopic procedures. So we know this very clearly. a lot of literature there to support that. This is from a paper that Dr. Breyer did from Aqua database, essentially highlighting that endoscopic management of urethral strictures is very overutilized, especially knowing that it has very poor long-term effects. And multiple endoscopic procedures is also very common, which does not fit our understanding of how poor long-term outcomes are. And then also, we know that age is a primary contributor to whether we offer patients endoscopic versus definitive management. And repeat endoscopic procedures is much more common in the elderly patients above age 65. You can see the drastic increase in utilization with age. So, and then this study here shows that urethroplasty is a successful management option for older patients. There's not an increase in failure with older patients, and there is not an increase in morbidity with older patients. This study was done by Dr. Hampson. It was a survey given to patients, and it actually showed that older men were more likely to prefer open reconstruction in the form of urethroplasty as opposed to endoscopic management. So this doesn't align with what we're offering patients. Despite them wanting the more definitive approach, they're much more likely to receive endoscopic management. And it doesn't come with no morbidity. This is a study within the VA population that shows that patients that are undergoing multiple endoscopic procedures, if they have a urethroplasty after the fact, they actually have worse outcomes and more morbidity. So my main focus was within the VA population, and luckily there's this care assessment need score that's automatically populated for patients. And it's been shown to be a good marker for looking at the risk of patients to be admitted or die within 90 days or a year. This scan was actually found to be validated against other frailty markers. So my thought is that the CAN score may be better in looking at frailty, may be more beneficial than just looking at patient's age, because age is just a number. You know, you walk in and there's an 80-year-old that looks robust and healthy. Then there's a 50-year-old that maybe looks like they're on their last leg. So for my main project, we are within the VA network, and we're looking at patients undergoing urethroplasty versus endoscopic management. And so unfortunately, we were a little delayed in getting our numbers back, but they are back now. So we have a cohort of patients and a bit over 300 patients that undergo urethroplasty and dilation within the VA population. And we're going to look at the utilization of urethroplasty, specifically looking at age and their frailty, and see how we're utilizing urethroplasty in this very vulnerable population. And we'll do multivariate analysis as well, as seen in this table. Unfortunately, I do not have the data back yet, but there's a little delay in getting the cohort, but it's underway, and we're still moving forward. And I'm happy to take any questions.
Alan, this CAD score, can we do that on our EPIC data? Did they pull that? So, because you're right, we see these patients and some of them look like they're 35 years old. They look like they act like they're 90. Is there an objective number that we could use on our routine EPIC that's done at the VA?
So the CAN score is VA specific. It's automatically populated in the VA system, but there are other frailty markers that I'm sure we could incorporate. It'd be very interesting, actually. Like, for example, I know Dr. Nguyen is a big fan of doing prostatectomies on 80-year-olds and such. So, but maybe a frailty marker would be better to assess patients, surgery, their surgical approaches.
Dr. Washington asked you, what is the geographic distribution of reconstructive urology within the VA? And would urethroplasty be widely available within the VA or just limited to a few sites? So for instance, if someone lives, 200 miles away at a VA hospital that is not all that well geared up, does that have an impact on some of this data?
That's actually a really great question. This was studied previously a few years ago, and it did show that geography was and distance away from an academic medical center within the VA system was a predictor of patients getting urethroplasty versus endoscopic surgery.
Alan, how do you want to take this kind of research forward as you move on with your career?
Yeah, I think ultimately I am interested in health disparities, and I think that age is a disparity that we forget about. We see the chart come up, and it's a 80-year-old. We start already before even seeing the patient start thinking about, oh, they're 80, maybe they need radiation versus this versus that, as opposed to actually treating these folks as individuals and assessing their robustness and whether they can actually undergo certain surgeries. So I think it's very important to keep in mind across all parts of urology and how we're treating folks based on their age.
From a philosophical point of view, Alan, why do you think some people don't do as well as they age and others do?
It's a series of events, how you live your life, I guess, choices you make, they're cumulative. If I had a do-over, I would have maybe slept in a couple more times during residency here and there, but no, I think it's just cumulative based on life decisions and such. And of course, genetics and everything else.
Right. Well, I'll just try to say that, we are very lucky and fortunate to be able to pursue these research endeavors to look at things that give you passion and get you excited to wake up in the morning to try to address these issues. And I can, as I'm looking at Peter on the screen here, when we were residents, the opportunities for doing transcriptomics in these large databases were really not available. And so we really live in a very exciting time where these resources are available to all of us and we can address what we believe are important questions.
And Marshall, let me just add that these opportunities are not available in most urology residency training programs. So I want to highlight the work that these people have done and the opportunities that UCSF provides for all of us.
Well, if there's no further questions, we'll give everybody an additional 8 minutes for their morning. And to each one of you, Avi, Mira, Alan, great job. And all the mentors that helped you, great job. So well done. Go after them, guys. Have a good day.